Hi everyone. So in this video I will be discussing about the basic implantology, wherein I would be discussing all the aspects of it, be it surgery, radiology or prosthetic. So I have also made videos on basic surgical techniques and the armamentarium. So if you are not confident enough with the surgical part of dentistry, I would request that you go back to that video, watch it and then come back to it. So for simplicity, I have divided the video in two parts. In the first part, we will discuss about osseointegration, classification of bone, different types of implants, the components, and the structure of endosteal implants. So let's start with the video. So first one is osseointegration. So osseointegration is basically the structural and functional union of implants and the bone. So we all know that the implants are placed inside your bone. So these implants are not just mechanically attached, but at the same time they have biological attachment as well. So in other words, the implants that you have placed, that is a part of bone once it gets osseointegrated. So, what are the factors for successful implant osseointegration? So, it doesn't happen that you have placed your implant and it would definitely osseointegrate. There are certain criteria which ensures that your implants will get successfully osseointegrated. There are more factors as well, but the basic ones are use of biologically compatible material. That means that the material that you are using should be biologically compatible. Next one is implant surface should be free of contamination and implant site should be free of infectious diseases. Atraumatic insertion technique. So how would you insert your implant atraumatically? So by using sharp drills, cool irrigating solution, sequential drilling, low speed and high torque drilling. So when we talk about sequential drilling, that means that the first drill, if it is 2 millimeter, the next drill should be 2.3 or 2.4, whatever you could provide. It shouldn't be like that the first drill that you have used is 2 millimeter and the next one is 4 millimeter. So whenever you are drilling, you have to drill in sequence. Low speed and high torque, not always true, but yes, when you are placing your implants, the speed should be low and the torque should be high, but in certain cases you need higher speed. So higher speed doesn't mean 1 lakh rotations per minute. 2500 or something like that is considered high, and 800 or 600, this is considered low with 20 newton per centimeter torque. So the torque is 20 newton per centimeter. This speed you can consider as low speed 800 to 600, and this speed 2500 or 2000 rpm can be your high speed. Next one is delayed loading of implants. So once you have placed your implants, you have to leave it for osseointegration and healing. So that ensures that sufficient time has been given to the implant and it gets osseointegrated. Classification of bone tissue. So what are the different types of bone that you would see in a human? So first one is a woven bone. So this bone is relatively weak, disorganized and poorly mineralized. It plays a crucial role in wound healing. Woven bone is not found in adults under normal condition. Rather, it is compacted to composite bone, remodeled to lamellar bone, or resorbed rapidly if prematurely loaded. So this particular statement, this needs a lot of explanation, especially when we would be dealing with immediate loading concept. That time I'll explain more about this particular thing. So next one is lamellar bone. So this is the common bone that most common bone that we see in human body. So it is strong and highly organized, well mineralized tissue, making up more than 99% of the human skeleton. Composite bone is basically an intermediate bone that gets replaced to that gets remodeled to lamellar bone. Bundle bone. So these bones are specialized bones that provides attachment to certain ligaments. In the case of tooth, it is periodontal ligament. So this is functional adaptation of lamellar structure to allow attachment of ligaments and tendons. Sharpie's fibers are the major distinguishing characteristics of bundle bone. Mesh bone density classification. So when we see a bone, we have two structures. The outer one, the thicker one, is called the cortical bone, whereas the inner trabecular network bone is called the cancellous bone. Alright, so in this diagram we can see the outer part is the cortical bone, whereas the inner part, showing trabecular network, is the cancellous bone. So this is the classification given by Carl Mesh. So he has classified bone on the basis of the cortical and cancellous bone, how these bones are organized. So in D1 bone, it is dense cortical bone, which is seen in the anterior mandibles. That means that the bone has more of cortical part and less of cancellous part. In D2 bone, the cortical bone is porous cortical and there is coarse trabecular bone. So in D2 bone, the cortical bone is not as strong as the D1 bone and the trabecular pattern is coarse. So where it is seen in the anterior mandible, posterior mandible and anterior maxilla. D3 bone. So D3 bone, it is porous cortical and fine trabecular. So difference between D2 and D3 is that the trabecular bone over here is weaker. So where would you find them? So it is usually seen in the anterior maxilla, posterior maxilla and posterior mandible. D4 bone, so it is fine trabecular, there is no cortical bone. So mostly this type of bone would be seen in the posterior and anterior maxilla, mostly in the posterior maxilla. D5, it is osteoid, so poorly mineralized bone graft. The bone graft that we place before it gets mineralized, it is in that D5 state, which is osteoid form. So these are various bones that we have discussed. This one is D1, this one is D2, this one is D3, this one is D4. So in this we have more of cortical, less of cancellous. In this, the cortical bone is porous and the trabecular bone, it is coarse. In D3 bone, what we see is the trabecular bone, it is fine. And in D4 bone, the cortical bone is not there only. Types of implants. So we have endosteal implants that we will be discussing in detail, eposteal or subperiosteal and transosteal implants. So endosteal implants, it is designed for placement into the alveolar bone or basal bone while maintaining the body of implant within the bone. So in endosteal bone, the implant is completely inside the bone. Suppose this is your bone, so the implant is in its three-dimensional form, completely inside the bone. So it can be in the form of blade, cylinder, or screw. Root form implants, that is either cylindrical or screw shape. So how do we categorize them? Cylindrical implants, they won't have threads. Screw shape implants, they would have threads. So this is the basic difference between the design. Here we can see this one is screw shape, this one is screw shape, and the middle two, it is cylindrical design. There are no threads. Okay, one piece versus two piece implants. So I think it is there in the next slide. Still, I would explain. So, okay, I'll explain it where it is given, because I have to explain the abutment and superstructure. So we'll skip this one. Subperiosteal implants. Subperiosteal implants, that means that the implant is placed beneath the periosteum, but the placement is not inside the bone. Not the implant is not completely inside the bone. It is placed over the bone beneath the subperiosteal implants. So the design would explain it further. So here we can see the implant is placed directly over the bone and not inside the bone. So these implants are specifically of great significance when you have atrophic jaws. When there is no sufficient bone, these implants can be a better option. Also, these implants are custom made. That means a scan is taken first and then it is designed. So for each individual, it would be different. Transosteal, that means through and through. These days we rarely come across these transosteal implants. So as I told, these implants are through and through. Structure and components of two-piece implants. Now let's talk about the endosteal implants. So the endosteal implants, it consists of two parts. The first one is implant body, that goes inside the bone. The next one is superstructure. So this superstructure, it gets attached to the implant body. So there are various superstructures such as cover screw, abutment, healing cap, multi-unit abutment. So in the surgical part, we will discuss where all these particular superstructures are used. So let's talk about the implant body. Implant body consists of following parts: the main body of implant, the apex, and crest module. Crest module is just the junction between implant body and superstructure. So this is the design. So this is the superstructure. Over here the superstructure is an abutment. So this abutment has been attached to the implant body by the means of abutment screw. now we see the endosteal implants, how they are classified on the basis of the aggressiveness of the thread. Okay, so we have seen the form implants, they have threads in it. So based on how aggressive these threads are, they have been classified as active implants, passive implants, universal implants. We'll see the diagram. The active implants, they have aggressive threads, so the depth of the thread is a lot more than the passive ones. Okay, so as we go from right to left, we see the implants are becoming less aggressive or more passive. Okay, on the left hand side we see a passive implants with least aggressive threads. So what are the significance of these threads? We have seen the active implants, they are placed in D3 D4 bone, and it gives higher primary stability. So primary stability is the frictional stability. When you place an implant, immediately it is not going to osseointegrate. So you get a particular stability which is a mechanical stability, that is called the primary stability. And yeah, that's all. That is the main advantage of active implant. Okay, one more thing, why active implants are not recommended for type 1 and type 2 bone. Since these implants, they provide a higher primary stability, that means the thread being more aggressive. When you place implant in D1 or D2 bone, it would actually be difficult to place them without giving extra torque, and this extra torque might create pressure necrosis. Okay, so we'll discuss about torque, and so we will discuss about torque in the subsequent slides. Okay, implant platforms and connections. So suppose this is your body of your implant. So we have two types of connections: internal connection and external connection. Connection means what is the type of connection that would allow the superstructure, it could be abutment or anything, to attach to the implant. So in internal connection, the hex part would be inside the body of implant, so that the superstructure can come and sit over it. So this is internal connection. In external connection, what we see is the hex is outside the body of implant, and now the abutment would come and sit over it. So this is internal, and this one is external. Okay, so in this diagram we can see these two are external, and all these are internal connection. Okay, so here is a terminology called hex. So although it is self-explanatory, but when we see these connection design, the design is in the form of hex. That's why it is called hex. Platform switching versus platform matching. So platform switching is something that okay, platform switching and platform matching. So platform switching, it means when the abutment is narrower than the implant at the connection. Platform matching means it features a butt joint where the implant diameter is similar to the abutment diameter at the connection. Okay, so we see this is the connection part. So in platform switching, the at the connection part, the diameter of the abutment is less than the connection. Okay, so this is the diameter of the connection and this is the diameter of the abutment. So it is less in case of platform switching. In case of platform matching, the diameter of abutment is similar to the diameter of the connection. See here, this is the diameter of the connection and this is the diameter of the abutment. So this is called platform matching. Alright, so is there any advantages of platform switching? Yes, there are. First, it prevents micro movement, and what it does, it does not allow bacterial penetration. So implant surgery, this part we will discuss in our next video. So in the next video we will be discussing about various surgical modalities, one stage versus two stage, CBCT reading and planning, and the prosthetic part, how impressions are taken. I'll try to make a video on it where I would demonstrate how we take impression and what are the different parts of the surgical kit. Thank you.